Hello and welcome to today's webinar organised by the ophthalmologist and Leica Microsystems. My name is Cedra Pavlou, Senior VP and Editorial Director of the Ophthalmologist, and I'm very pleased to be the moderator of today's online event, which will see two world-renowned surgeons explore several advanced cataract and refractive surgery techniques, and they'll explain how Leica microscopes can be used to aid in these procedures. I'll just briefly show a disclaimer to all of our viewers there. And I will now go on to introducing our guest speakers. It gives me great pleasure today to introduce our speakers, Dr. Vance Thompson and Dr. Majid Moshirfar. Dr. Vance Thompson is an internationally recognized specialist in laser vision correction and advanced cataract surgery. He's the founder and the director of refractive surgery of Vance Thompson Vision in Sioux Falls. He also serves as a professor of ophthalmology at the Sanford University of South Dakota School of Medicine. As a leading international researcher, Dr. Thompson has led more than 80 FDA clinical trials, published numerous papers and book chapters, and he's played a key role in the development of the most advanced technologies and techniques for both laser and implant vision correction. We're so happy to have you with us today, Dr. Thompson.
Thank you.
I am also delighted to welcome our second speaker today, Clinical Director and Fellowship Director at Hoops Vision in Utah, Dr. Majid Moshirfar. An internationally renowned corneal and refractive surgeon, Dr. Moshirfar has a strong history of innovation in corneal surgery and in clinical research, as well as a prolific legacy of academic teaching, publishing, and speaking, authoring more than 200 peer-reviewed publications and serving on the editorial boards of numerous scientific journals. He specializes in refractive surgeries such as LASIK, PRK and ICL, as well as corneal transplantation, keratoprosthesis, and management of difficult corneal disorders. And he's played a leading role in the development and dissemination of these procedures, particularly in the area of challenging refractive surgery techniques. Thank you for joining us, Dr. Moshirfar. So today you will benefit, yes, thank you, and audience members, today you will benefit from the wealth of experience of these two speakers who will guide you through a number of advanced cataract and refractive techniques, explaining how Leica microscopes can help you achieve optimal outcomes from your surgeries. Both speakers will be on hand to answer any questions that you have at the end of the presentation. But please remember that you can submit questions at any time throughout the webinar, so I encourage you to do so. Without further ado, let me get today's event underway by passing you on to our first presenter, Dr. Vance Thompson. Dr. Thompson, over to you.
What a pleasure to be here with you all, and hopefully you can see my slides just fine. Are they showing up nicely?
Yes, they are, Dr. Thompson.
Thank you. And thank you, Leica, for all your wonderful work in technology and organizing this seminar. And I'm honored to be doing this with Dr. Moshirfar, who I have a lot of respect for. And I'm going to be spending time talking about something I did multiple times today, and I do every day in cataract surgery, and that is centering cataract surgery on the visual axis and the Purkinje images. And I have a tendency to approach cataract surgery from a refractive surgery perspective because not only am I fascinated with refractive surgery, cataract surgery happens to be the most powerful cataract surgery there is. These are my financial disclosures, and this is my goal. Every cataract surgery to get a round, centered on the visual axis, not the pupil, capsulotomy, in addition to centering the implant. But when that implant is beautifully centered, the capsulotomy beautifully centered, I know that patient has a very high chance of being happy for the long run. And I made this little drawing to just show what my goal is with anterior capsule overlap of the optic for 360 degrees. Because if I don't get that, the anterior capsule underneath it, especially in the mid-periphery and peripheral zone, the lens epithelial cells are very concentrated and reactive. And as that anterior leaflet fuses to the posterior capsule, it sets off a sequence of events of an aggressive fibrotic reaction that takes your beautifully centered implant and can increase the chance of tilt and decentration. Now we know that this isn't new. This was described by Dr. David Apple and others years ago. And there's been many publications describing this pearl type posterior capsule opacification that is less aggressive. And you know when you're doing your YAG laser capsulotomy and it's taking you 8 to 20 pulses to create the opening, that you would rather have that than the fibrotic, more aggressive posterior capsule opacification that can take multiple pulses to get through. And what we have to realize, though, is that we are in control of that. Others have talked about the apposition of the anterior capsule edge to the posterior capsule being dangerous, putting the eye at increased risk. And how do we prevent this from happening in cataract surgery? Dr. Alan Carlson even talked about how incomplete overlap of the optic creates this capsular fusion that isn't static, it's progressive, and it can actually zipper the implant for 360 degrees in some cases, even though it started out as just part of the implant not having overlap. And when you get this complete fusion of the anterior capsule to the posterior capsule, what I like to call capsular fusion syndrome, you have no idea where your implant is going to be centered and the tilt you're dealing with. And we know with modern day aspheric implants, beautiful monofocals, that asphericity is nullified above 0.5 millimeters, 0.6 millimeters decentration. And so even in our monofocals it matters, but it really matters in our multifocals. But this opacification, we can control how aggressive it is. And we want to try to minimize this progressive adherence so we don't get this capsular fusion syndrome. And so this 360 degrees of overlap is something you can do with a femtosecond laser, OCT guided. And again, you don't want to center on the pupil, you want to center on the lens. Or you can do it manually, and I'm going to show that. Or you can do it with other automated technology like Zepto. And so let's talk a little bit about how we do this. We know that there's reflected images that are called catoptric images, and this reflection that occurs off of mirror-like surfaces can be used also in the eye. That was first described by the Czech anatomist and physiologist, Dr. Purkinje, who actually first described protoplasm, and he also described the Purkinje fibers in the central nervous system and many other anatomical things, just a very prolific anatomist. And he was the first to talk about these images, and Dr. Sanson, a French surgeon and ophthalmologist, also was very involved in using and teaching, and so sometimes you hear it called the Purkinje-Sanson images. And basically, Purkinje 1 is a reflection off the anterior cornea. Purkinje 2, the posterior cornea, Purkinje 3, the anterior lens. And all three of these are convex surfaces, and so the reflected image is actually an upright reflection. And then Purkinje 4, since it's off of the posterior lens and it's concave, is an inverted reflection. And actually many tracking devices use Purkinje 1 and 4 for very reliable tracking. But it's also useful for sending in cataract surgery, not only the implant, but also the capsulotomy. And I'm going to be playing these videos just because I am not in presenter mode. I'll just be doing this manually, which works just fine. But everybody has these first and fourth Purkinje images. I'm pointing there at the third, which is somewhere in the vitreous. But the really useful ones are the first and the fourth. And when those are in the patient-fixated relationship, it's a very reproducible relationship. And so sometimes what I'll do, if a patient is very sleepy or they're having a hard time fixating, I actually can reproduce the P1, P4 relationship as a surrogate for patient fixation. And so I can, whether the patient can fixate or not, I can use this to my advantage in surgery. And Dr. Jack Holliday, I'll never forget the first day we sat in a hotel and he sent me out to get a magnifying lens to show me with a flashlight how I could actually do this. And I remember going to my hotel room and looking at the ceiling light and putting my little magnifier in a way that I could look at the Purkinje images from it, but I was having a hard time telling which one was the inverted one because it was a circle. So I took the candy jar and taped it up there on the light, and then I could tell, which one was the upright image and which one was the inverted image, and that you could bring them together and center it just like in an eye. So these Purkinje images are everywhere. And this first on my Leica scope almost looks like what I would call kind eyes. It's the brightest reflection. And then the fourth, since it's an inverted image on my Leica scope, I think it looks like sinister eyes. And when the patient fixates, I can use that to my advantage. And if I need to, recreate that. And I have a few cases where I show you how I do that in this presentation. So if a patient is not fixating properly, the Purkinje images aren't very reliable. When they fixate, there's a very unique relationship that can be used to center cataract surgery and your implant. And if we just look here, here's a case that the patient was having a hard time fixating, and all I did was align them myself, and then I centered my capsulotomy as my surrogate for patient fixation. So when I do manual cataract surgery, I use a 6mm optical zone, and I center it on the patient fixated first and fourth Purkinje image. And I do this on every manual case, and you cannot tell if your imprint is well centered unless the patient fixates. And then I can tell I did a good job, and I can use that as my guide in the cataract surgery. And so here's a case where I, again, was having a hard time getting the patient to look at the light. So I aligned it, did my imprint, and then I did my capsulotomy. And you have to continually realign 1 and 4 when you're doing what I call a refractive capsulotomy. If you really want to get 360 degrees of overlap on every patient, you work hard to realign 1 and 4 multiple times during the capsulotomy. And this patient ended up doing real well with a nice, not only well-centered implant, but also a well-centered capsulotomy. And so you can see here, we've got nice overlap. I like using a barokeratinometer to check pressure postoperatively. And so the Zepto technology, what I like about that is I can actually use the same technique, only my Zepto technology ends up being a marker and a capsulotomy device. So I don't have to mark and then continually realign during my capsulorhexis. With this, I'm centering using the Zepto technology and the Purkinje method, and then performing the capsulotomy. And so here is a case. I've aligned 1 and 4. I've inserted the Zepto. And when I'm happy with my centration, I ask for suction. I can see my nice Leica Purkinje 1 and 4. I ask for energy. There's the energy delivered in very quickly. You get an auto hydrodissection with the release of the device. And then I go ahead and do my phaco emulsification. I get a nice capsulotomy, and I get an implant that so far isn't centered perfectly. And this is where, when you know your capsulotomy is well centered, it can serve as a guide that I need to work on centering my implant better also. And I nudge this implant around, and sometimes you just simply need to rotate it to find its happy spot. And then I have a well-centered implant and a well-centered capsulotomy, and that patient will do well on the long run. And they indeed did. And I actually eventually did do a capsulotomy on this patient, a YAG laser capsulotomy. And it took 22 pulses, and it was just a nice pearl type PCO and not that aggressive fibrotic type. And so the capsulotomy in this light adjustable lens was well centered. This patient's going to do well for a long time. And I published this in the JCRS journal. It actually won the Rosen Award last year at the ESCRS for New Surgical Technique of the Year. But you can do this manually. You can do it with OCT guided femto. You can do it with Zepto. But manually in Zepto, the Purkinje images using the Leica microscope work just beautiful. And I'll be excited to answer questions during the Q&A session.
Thank you so much for that, Dr. Thompson, and apologies again for the little interruption there in the middle of your presentation, the slight technical hiccup that we had there, and thank you so much for working with us to address that, and very much appreciated, and thanks for a wonderful presentation. I would now like to hand over to our second speaker of the evening, Dr. Moshirfar, who will also be sharing his presentation with us momentarily. Welcome, Dr. Moshirfar.
I have to tell you, it's really my honor to share the same webinar with Dr. Vance Thompson, one of the nicest and the most intelligent ophthalmologists I know. I really feel honored to be in the company of such a great man. And I also want to thank Leica team and also the ophthalmologist editorial staff for putting this together. What I'm going to do in the next 15 minutes is simply share with you how I do centration when it comes to refractive surgeries using the Leica platform, and simply try to share a few videotapes with you and see if that can leave some home messages for our audience in terms of helping them with some of the centration issues. These are my financial disclosures. that I wanted to share, and I have been sponsored by Leica Microscope to give this presentation. As my good colleague Dr. Thompson mentioned and gave us the beautiful historical background for Purkinje, we definitely are quite aware about the Purkinje image 1, which is primarily from the anterior surface of the cornea. And for me, as a clinician, I always try to find the first Purkinje image. I have to admit that it is quite difficult for me to see the fourth or the third Purkinje image most of the time, but on a day-to-day basis, I do my best in most of my corneal procedures and as well in cataract surgery to really find where the Purkinje image 1 is by doing that through the coaxial corneal reflex from the microscope on Leica platform. And it provides me an idea, and even though we all have our preoperative diagnostic devices that can help us know where the Purkinje reflex or the corneal light reflex is, but also knowing that where it is with respect to the geometric corneal limbus and where it is with respect to the mesopic and photopic pupil gives you an idea of the displacement of the corneal light reflex from the center of the pupil or the geometric corneal limbus. And by knowing that ahead of time and then in the operating room, as Dr. Thompson said, you can have a better understanding of how to do your centration when it comes to your capsular rhexis, or when it comes to the centration in the hyperopic LASIK procedure, or for that matter, if you are doing some inlay procedure, it again can help you and guide you ahead of time in your surgical planning. And what I like about the Leica microscope is that when I'm looking through the observer scope and I see this beautiful Purkinje image 1, and I can see how geometrically overall is concentric with respect to the geometric pupil and also the geometric limbus, I feel better. I really feel better that my capsular rhexis is concentric with respect to all those anatomy, and it helps me guide me when I am doing my, for example, premium IOL procedures. And as Dr. Thompson mentioned, by having that ability to center things with respect to the displacement of the Purkinje reflex with respect to the pupil in somebody who has an angle kappa of, let's say, 0.3 millimeter or 0.5 millimeter, and in some high hyperopes that can be even higher, you can respect that centration and enhance the optical quality of your procedure, whether it's a cornea or a lenticular approach. What I'm trying to show here is simply what we do in a patient who is undergoing, let's say, one of these premium intraocular lenses. I have the ability to have a fixation light that my patient is looking at. And what I like about Leica is that I can dim the light a lot, so it's easy for the patient. And this is the point, the most important step. And I always like to use a small optical zone to center. And then when it comes to the geometric limbus on the cornea, I actually use the fixation ring, and I am putting the 5.5 millimeter capsular rhexis optical zone marker. Now, if you pay attention here, you can see that the inner circle is not completely concentric with respect to the 5.5 millimeter larger circle, which again, it shows you that the inner circle was placed with respect to the visual axis or the corneal vertex, whereas the bigger one was placed with respect to the geometric cornea and the limbus. And that's why you can see the inner circle should be always a little bit more nasal if you put it with respect to the Purkinje image 1. And then this allows me that as the patient is looking at the red reflex, I turn the lights down like that, and they're looking at that red reflex. And I do this multiple times at the end when I'm doing my finishing touches to make sure that I get that centration as the patient is looking at that red flashing fixation light, which is basically between those two filament reflections from the Leica microscope. And again, you'll see that I turn the lights down, and the individual is looking at that red reflex, the red flashing light, and then I double check that, and at that point I feel comfortable that I try to put this in a proper position. Now, it is true that no matter what we do, again, afterwards, there's always a chance of movement of the lens, and there's so many other factors, but this enables me that at the end of the procedure, I have centered it, and I respected the basically the centration of the patients with respect to the lens. Now, this is also important in other platforms. Let's say if somebody is doing one of those small aperture intraocular lenses, even though the small aperture intraocular lens that has a small opening in it, 1.6 millimeter, and it's closer to the nodal point, and since it is closer to the nodal point, it is more forgiving than if you were putting that in a cornea. Again, by having that Purkinje image from the Leica microscope, one can put this small aperture IOL inside the eye and try to center that inner 1.6 millimeter from this IOL with respect to the Purkinje reflex and also the fixation light that the patient is looking at. Now, some of us may not have the fixation light on our microscope. We may just have the two Purkinje. But again, being able to look at that and try to make that center 1.6 millimeter of this small aperture concentric with respect to that red Purkinje image makes it so that you can be more satisfied with your centration, because sometimes you may have to move it slightly nasal or temporal. Granted, you're closer to the nodal point, so it may be more forgiving, but I've noticed that this would make this even more rewarding at the end of the case, and you will have a better result afterwards. Now, I also do the same thing, try to use the Leica with regard to centration of my ICL, whether it's the regular ICL or the ICL that has an aqua port. I like the fact that when I put my ICL inside the eye and I put it on in the posterior chamber, I make sure that the foot plates are hopefully lying over the ciliary body to ciliary body, and I'm not tilted nasally or temporally, but more importantly, at the end, I look at that Purkinje image. And by looking at that Purkinje image at the end of the procedure, when I remove the viscoelastic, I can say the optic of that ICL is completely centered with respect to my corneal light reflex. And if that's the case, then I know my lens is not inferior, my lens is not superior, and even if I have an aqua port, I can make sure my aqua port is between those two light reflexes that are coming from the Leica microscope. And this way, I can be certain that next day my lens doesn't look inferior or superior, hopefully. Again, another thing that I do for centration using the Leica microscope on a day-to-day basis, when I have the dilated high myope that I'm putting the ICL inside their eyes, whether there is an aqua port or not, this way I can make sure my optics are completely centered with respect to the Purkinje image. Now, when it comes to corneal procedures such as raindrop or Kamra, I truly think that we are way away from the nodal point. And when we're way away from the nodal point, it is even more critical to do a good centration of your initial mark and hoping that that initial mark is in the right place. True, if you have your preoperative diagnostic devices that can give you some guidance of where it needs to be, but that centration is quite important. That's why when I do it, I really hold my breath when I'm making that small marking. And if you look closely here, you can see that the center of the pupil and the center of my mark are not the same. And if anything, my mark is slightly nasal. And that's because I truly know that this patient's center or the corneal reflex or the corneal vertex was slightly more nasal. And that makes me feel good because I know from now on all the rest of the procedure is kind of like very automated. And, you know, whatever platform you use is going to make your pocket. And then after that, you are putting your inlay in. whether it's a raindrop, whether it's a camera, whether it's a presbya, and it's very difficult at this point to expect the patient to look at the light to great accuracy, and for you as a surgeon to know how you can really make this central with respect to that Purkinje reflex, because your reflex is not going to have a very good image. But if your mark in the beginning was well determined and well delineated and was nicely placed with great confidence, then you can be sure that at the end of the procedure you actually have a very good understanding, because you can look into this inner 1.6 millimeter and you can hope that your Purkinje and your red reflex is in the right spot. And I truly think that when it comes to centration on corneal procedure, I really like to use this platform. And we know that actually in future, Leica microscope is going to give us the ability to actually create a shadow of the camera inlay or even raindrop to enable us to do that without us having a mark and hoping that your mark is going to stay there forever. We also use the Leica microscope quite frequently when we want to do centration of other inlays, such as human allograft. And this is the example of a patient with a high hyperope. Now we're dealing with +8s and +7s, and these patients have a huge angle kappa, and they have a huge displacement of their basically corneal vertex or their line of sight with respect to the center of the pupil. When we make their flap, of course the flap has to be huge, because we know sometimes the lenticule, which is sometimes 7 millimeter, needs to be more nasal. And these flaps, we're talking 10 millimeter flaps sometimes, and the marks are done in a cardinal format with respect to where you think the geometric cornea is. But when we are placing the actual allograft, in this situation harvested from an eye bank, and it is basically +8 that we are putting on the surface after lifting the flap, not only it requires to have a proper orientation anteriorly and posteriorly, but it also needs to have basically some alignment that we can use for our marking. And as you see here, we are trying to, I'm going to bring it to that point, we're trying to put this on in a way that all these lines are properly aligned with the marks that are on the lenticule of the graft. And we have to kind of wait, just like reminiscent of raindrop, very similar to raindrop, you have to put the flap back very slowly so that there is less chance of the lenticule actually displacing. And you can see that here in this diagram here, and that lenticule is in place, and it's very important to respect the centration of that. Now, I must tell you that the reason I like a microscope, and it may sound that I'm a little bit biased, is because after 26 years of using all kinds of microscope, I find Leica microscope makes an average surgeon like myself provide a much better quality care to the patient. I can see things that I couldn't see if I was using other platforms sometimes. It gives me a very good large field of view, and I have a very good depth in my focusing, and the resolution is so that when I'm sitting in the assistant scope and the fellow is sitting in the main surgical scope, there is only 70% of split of light, not 50-50, and I can still have a very good view of what's happening. And it gives me that ability so that if sometimes I am doing procedures, like let's say I'm doing a smile procedure and I'm doing a very thin lenticule, 1.75, 1.5 diopter lenticule, if in a smile procedure I have a hard time seeing the anterior dissection or the posterior dissection with other platforms such as VisioMax, if I transfer the patient to the Leica microscope, all of a sudden I can see with a greater ease how to remove the lenticule with a greater confidence, especially if I'm dealing with a very thin lenticule with a low myopic power. It also saves me sometimes if I feel like I have few remnants in the periphery of my smile. So it has saved me a few times in difficult dissections of smile as well. So it's been a good thing for me in that regard. And one other thing is that for some reason it doesn't seem bulky to me. The post is not in my way, and the handles are very easy. You don't need to have big muscles to move them up and down, and it has a good ergonomic, and I personally like it. And I don't have the ceiling mounted Leica microscope. Mine are the ones with the post on the side, and I have to tell you, the ergonomics of the microscope is very, very good. And I have to tell you, this technology and this company has been around for 100 years. They are pioneers when it comes to other surgical microscopes, not just for us, but for other subspecialties of medicine. And they were the ones who actually came up with a 35mm camera in the beginning. So they have provided a good service to me, and I use them on a day-to-day basis. And I think they are a very good platform when somebody wants to look into acquiring a new microscope. At this point, I want to stop this presentation and see if you have any questions for Dr. Thompson or for myself.
Perfect, Dr. Moshirfar. Thank you so much for your presentation. And like you say, we are about ready to get our Q&A session started with yourself and Dr. Thompson. Dr. Thompson, if we can bring you back in to the audio, that would be wonderful. Unsurprisingly, we've received some questions from our audience members tonight for you both. So let's try and get through as many as we can with what time we have remaining. But I just wanted to assure audience members, if your questions are unanswered live today by our esteemed doctors, I would like to reassure you that they will be answered after this event by email. So thank you very much again, Dr. Thompson, Dr. Moshirfar, for such insightful presentations there. So I'll get started with our very first question. Both of you, actually, I'm going to put this one to both of you. I wanted to ask how you would compare, based on your experience, with the Leica red reflex to other microscopes. Dr. Moshirfar, do you want to kick us off with your thoughts on that?
I personally find the red reflex so good on this platform that when we're working with fellows and residents, we don't necessarily need to use any of those vision blue to do a capsule rexis. I know that a lot of the younger ophthalmologists prefer to use the vision blue when they're doing the capsule rexis, but the red reflex on Leica platform is so good that I hardly have problem, and it just has a good, not only a good intensity, and you don't even need to move the microscope too much or tilt the microscope too much to get a very good reflex. So I have never done a study, and I don't know, but I'm sure other platforms claim the same. But in my opinion, I work with 2 other microscopes on a weekly basis with other great companies, but Leica gives me the best red reflex.
Great. Thank you for that, Dr. Moshirfar. Dr. Thompson, what would be your response to that? How do you feel Leica red reflex compares to other microscopes based on your experience?
Yeah, I feel like it gives me a very quality red reflex. I've used it for many years, and so I'm very comfortable with it, and don't really have anything to add except that I'm very happy with it.
Yeah, well, great. You can't ask for more than that, that's for sure. And can you tell us, in terms of the configuration, do you have a floor standing or ceiling mount configuration, and how does that impact your workflow and ergonomics?
I don't have a ceiling mounted version either, and it doesn't impact my workflow. I do like to make sure that the base is far enough down on the patient bed that I can, get my foot pedal far enough away from the angle of my leg. And but it's, we have a great routine and a great system, and I actually use it to my advantage too, because on the floor-mounted scope, there's, room for us to, we have little hooks that we have taped on there for topographies and patient information, and so I actually have a lot of information happening there right in front of me too. But it works very well for us.
Great. And Dr. Moshirfar, what is your experience in terms of the configuration? What is the setup like in your clinic, in your OR?
Well, currently I don't have a ceiling-mounted Leica platform. Mine is just like Dr. Thompson, but in the past I've had the opportunity to work with the ceiling-mounted one, and I have to tell you, I don't find one superior to the other. But if finance is not an issue, I would still encourage people who have a smaller surface area in their surgical center to go with the ceiling-mounted one. And I work with a ceiling-mounted one for almost 15 years, and they're fantastic. But I don't find the ones that are not ceiling-mounted to be of any problem. I don't find them to be bulky. They're not taking too much space. And I think both platforms are working fine in the hand of most clinicians.
Great. Thank you so much for that. And just looking at other technologies that are out there, Dr. Moshirfar, what are some of the other technologies that work that you've found work well in tandem with your Leica microscope?
Well, I have done other types of inlay procedures, whether it's human or non-human, using the Leica microscope, and I really like it. I find it wonderful when I'm trying to remove epithelial downgrowth and epithelial ingrowth, which sometimes is very difficult to see. And I personally find the view so good when it comes to endothelial transplantation. I realize that the newer platforms of most of our microscopes, including Leica, they have the ability to have an OCT system on them, but the resolution of image is so nice and the reflexes are so good on these microscopes that I can do a DSEC with this technology and a DMEC without having too much problem seeing the tissue. I don't find it difficult. And when it comes to doing a DALK and getting the big bubble and trying to find that layer, or if you don't, trying to actually very slowly do stromal dissection layer by layer, it's just a very good microscope. What I also like about it is the fact that on some of my patients who are young and they're getting refractive lens exchange in their 50s and they can't tolerate looking at the bright light, I can make this microscope be on 3% or 2% illumination. Now we're talking 3% out of 100. And I have an easy time doing what I need to do, and patients can look at it, and the fixation can be a lot easier. So most of my time when I'm using the Leica microscope, I hardly ever go more than 12% on my illumination. And for most people, it can be 2 or 3% when I'm doing my capsulorhexis or the beginning of the procedure.
Okay, wonderful. Thank you for that, Dr. Moshirfar. Dr. Thompson, can we move on to quite a topical question, which I'm sure, both of you have probably had asked of you at one time or another recently, more often than probably quite a few times. The current pandemic that we all find ourselves in. Can I ask you first, Dr. Thompson? I know I've spoken with a lot of doctors recently about how they and their practice have been impacted. What are some of the kind of major impacts that have been that you have noticed with your practice, and actually for you professionally as well, Dr. Thompson?
So we, listened very closely to what was happening, with the rest of the world, and then with our societies and our local hospitals, and because we just felt like we needed to stop elective surgery when we were suggested to do that, which was a couple weeks before our hospital system. And we waited until a couple weeks after the hospital system restarted elective surgery. So we had a 2.5 months of not doing surgery. We did stay open for urgent and emergent cases, but elective is 95% of what we do. And so when you have a large team, we had the business end of it we had to figure out. So that was very difficult with such a high overhead, used to high volume surgery when it goes down to almost nothing. And so the business, we're still working out of that hole, but we are working, and we opened May 12th, and it was amazing to us how many people wanted refractive and cataract surgery, and the energy continues and the phone continues. The limitation hasn't been the patients coming in. The limitation has been how do we process them, and we extended our waiting room to the parking lot. So they have to come, and they have a text message that we're communicating with them, and the patient comes in, the driver stays in the car, and then the waiting room is very spacious and socially distanced. There's a lot of chairs missing, but since we have an extension into the parking lot, that works, and we check everybody's temperature, and everybody's wearing masks. And so we ask about symptoms. Nobody can come in who's had symptoms or exposure to someone with COVID. But I have to tell you that after that, once it gets into clinic and surgery, it's automatically socially distanced, and we've been able to work up to our reasonable, regular volumes pretty quickly. But everything short of the patient starting their journey into clinic or surgery is done a lot slower. So it's a administrative choreography that's going on, but it's going quite well, and people are happy to be out.
Yeah, absolutely. Thank you for that. I mean, you called it administrative choreography. With that now having to be the case, that the admin side of admitting your patients being so much of a longer process, roughly, have you seen obviously a substantially lower volume of patients that you're now able to deal with as a result of that administration kind of increase?
Yes. I need to add that the telemedicine component has really been utilized. I have a hard time a little bit with the word telemedicine because we use such sophisticated technology in ophthalmology. It's hard to do a great exam and any diagnostics. So I call it tele-talking or telecommunications. But it is very helpful because, we do a lot of talking, a lot of patient education in refractive and cataract surgery. And so when you can move that to their home and have the counselors and the technicians and the doctors doing a lot of what they did in the office, out of the office. So once they get to the office, we're just doing diagnostics. We're just double checking certain measurements and then doing surgery. So we've moved a lot of things outside of the office. And as a result, that's increased efficiency, and we can do our pre-COVID volumes now that we've got our full team back.
Wow, that's incredible. I mean, Dr. Thompson, you've kind of explained in terms of the pre-surgical and diagnostic process, there have been a lot of changes and a big emphasis on telemedicine. Do you actually think beyond whenever things do return to seeming normality, do you actually think there's going to be a real long-term change in the way that treatment consultation is administered by ophthalmologists?
I think that what we're putting in place now will be how we'll practice for the rest of my career, and this has worked actually very well. And we've established a connection with the patient earlier and deeper than when we did everything in the office. And I thought it was going to be colder and hard to do a patient experience, but patients love when you show them a certain amount of attention and you're fussing over them and caring. And when you have all these extra steps and you respect them and you don't cut corners, the thank yous that we're getting, because when they go to businesses that don't do that, they are worried because there's fear out there. And it's an amazing opportunity, which I never would have guessed, to show a wonderful patient experience. And I do think it will permanently change the practice of medicine.
It's a very, very positive, that's a very positive view there, Dr. Thompson. Thank you so much for that. Just want to, if I may ask one final question, we're right at the end of our time. It's flown by, so I'm just going to squeeze one more in, if I may. About virtual trade shows, obviously, that's changed for sure. For how long? Who knows? Certainly this year we've seen all of our major trade shows in the ophthalmic space cancelled or virtualized. What do you think will be the future of events? Do you see a return to the traditional format of conferences? Dr. Moshirfar, do you want to jump in and tell me what you think on that one?
Well, I think, as Dr. Thompson said, there's going to be a new normalcy. We're going to have a new way of looking at things, and it's going to be a good thing in many ways and a more efficient way. I mean, I'm noticing that even though all the businesses and all the companies are starting to get back, you see less traffic and the air is better and people can do things remotely. Many professionals can do their things from off-site, not necessarily in their offices. So I think there's going to be a new normal, which is much better, much more mainstream, much more efficient in all disciplines, not just in our field. And from my point of view, in terms of meetings and all that, I have to tell you that a lot of our fellows and students, they actually now try to learn things online. There's all kinds of webinars that people can go and listen to. They don't have to travel somewhere and go and stay in a hotel. And so in many ways, I think that the information can be transmitted a lot more efficient without us actually traveling somewhere physically. And with the new software platforms, the communication is so much more efficient that we may not necessarily need to actually physically go from places to places to acquire knowledge or share knowledge, but we can most likely do all of that through the existing platforms that we have on computers and other media.
Right. Yeah. Thank you. Absolutely. I mean, Dr. Thompson, conferences and events are such an enormous part of learning, I guess, and networking and meeting with your peers. What are your thoughts on the future of the conference and exhibition?
I think that we're going to see a hybrid. I agree with everything that Dr. Moshirfar just said. And one of the things I wanted to add is he had my full attention during that beautiful presentation. And sometimes when I'm at a meeting and I can't hear the audio as well, or the person next to me is asking me a question, I don't get a focus as much as I did during that amazing presentation. And I think there's some advantages to virtual, or even your, facilitating. It's been such a beautiful rhythm to it that I like the virtual way more than I ever would have imagined. And we can talk to our friends all around the world, and they get to sleep in their own bed tonight. And, Leica went to all this trouble. And so I think that virtual is here to stay. I think that humans love personal interaction, so there'll be a certain amount of real. But I think there'll be hybrids. And I think there'll be people that will choose the real, people that will choose 100% virtual, and people will want the hybrid. But what I love about the virtual is 100% full attention.
Okay. Thank you so much. What a great way to end. That was not scripted, so it sounded like it was, but it definitely wasn't. It was a wonderful way to end this event. Dr. Thompson, Dr. Moshirfar, thank you so much. I'm afraid that's all we have time for this evening, but just wanted to reassure our audience members again that any questions left unanswered today will be answered after the event by email. But on behalf of everyone at The Ophthalmologist, I would like to thank our exceptional speakers tonight once again for sharing your expertise and your insight with us. Thank you so much. Honestly, myself, it's been a real honor to work with you both on this. Thank you. Thank you also to our audience for joining us today. And of course, it goes without saying, thank you to our sponsors, Leica Microsystems, for supporting this event. Thank you very much. The event will be available on demand after this evening, so keep an eye out for the link, which will be emailed to everyone who has registered in the coming days. And actually, you know, share the link. Anyone can register to listen to this fantastic presentation by some exceptional surgeons. So thank you again to everyone, in particular Dr. Moshirfar, Dr. Thompson, thank you both very much. And to our audience members, I look forward to seeing you all at future webinars. So thank you and good night.